The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we're thrilled to have Dr. Lindsay Kranker here to review the management of all things wounds and wound care. Dr. Kranker is an assistant professor in the section of acute and critical care surgery and the associate clerkship director at Washington University in St. Louis. My name is Tiffany Brocke, and I'm a general surgery resident, and I'll be your host for this episode.
Thanks, Tiffany, for having me. While wounds aren't the most glamorous of topics, it's certainly fundamental and important to our patients.
Humans have been treating wounds for thousands of years, and certainly some of the greatest advances in surgical medicine have related to the understanding of how to help wounds heal. Surgeons are often faced with patients needing wound care, either for wounds that the surgeon created or otherwise, and it's important to be able to recognize a wound that's healing normally versus one that's not.
One of the most complex and specialized categories of wounds we care for is related to necrotizing soft tissue infection, or NSTI. NSTI represents a huge burden of disease with an incidence of 10 per 100,000 in the U.S., which is actually increasing, and mortality greater than 30% worldwide. We're going to talk about both the early diagnosis and treatment of NSTI and some tips for wound care for these patients. Let's dive right into a case scenario to guide our discussion. A 42-year-old female presents to the emergency department with 5 days of a boil near her groin and 2 days of fever and severely worsening pain over the area. How would you like to start your workup?
Well, I'd of course go to the bedside and start with a history and physical. For HPI, classically these patients would have very rapidly progressing symptoms over a period of a few hours, even being able to notice some, changes in their wounds over less than a day sometimes, fever, malaise, potentially fatigue. For past medical history, you'd want to know if they have a history of prior similar presentations or skin and soft tissue infections, if they have a history of type 2 diabetes, obesity, any history of immunosuppressive medications or immune disorders that could make them susceptible to some potentially unusual organisms, and then what their home medications are. For past surgical history, I'd want to know if they have any retained hardware in the area, AV graft or orthopedic kind of hardware, or if they have a history of chronic hidradenitis with prior resections in that area. That's actually a reassuring sign for the status of the soft tissue. For social history, I would want to know if they have a personal history of smoking, since that will impact their wound healing, their nutrition kind of status. Similarly, if they have a history of injection drug use, that is a risk factor for soft tissue infection and could potentially be contributing to the underlying infection. And then if they have family contact or who they want to make medical decisions for them. On exam, I would look for cellulitis in the area of pain, would outline that with a marker if it hasn't already been. If it's a perineal type of infection, I would want to make sure to look at the back and the buttocks to see if there's infection kind of progressing posteriorly. You'd look for crepitus on exam, desquamating skin or bullae, petechiae, skin necrosis, severe pain on exam, even if the overlying tissue looks normal. And then, of course, want to look at their vital signs. If they're getting tachycardic or hypotensive, that would make me concerned that she might be developing septic shock. For other kind of data points, hopefully the ED has already sent some labs. The kind of testable item for necrotizing soft tissue infection is the Larinic score, which stands for Laboratory Risk Indicator for Necrotizing Fasciitis. And that includes data points related to the CRP, the white blood cell count, the hemoglobin. Hyponatremia is kind of classically tested and shows up sometimes in person as well. Elevated creatinine and elevated glucose. Dr. Kranker, how do you incorporate imaging for these patients?
So definitely this is a clinical diagnosis, not an imaging diagnosis, but I think it can have some important utility. Specifically, it can be attained promptly and not delay time to the OR. The imaging findings you're looking for is typically subcutaneous emphysema, fluid tracking along the fascial planes, and actually loss of fascial enhancement has been shown on CT to be more sensitive. It can also be reassuring. So, for example, if you have a fistula in ana where the opening in the rectum is allowing air fluid to enter, a perianal abscess will sometimes have an air fluid level, but it will be well circumscribed abscess cavity. I tend to maybe obtain CT not to make my decision on surgery, but to plan the surgery. So, taking the patient by the CT scanner from the ED is very easy in our institution, while the OR is opening up the instruments, particularly if it's going to help me understand the extent of the disease and plan operative positioning. And then for an ambiguous presentation, or particularly if the patient has uncontrolled disease, they've gone through 2 or 3 debridements and they're just not clinically improving, still profoundly septic, sometimes looking for a further infection, or in rare cases you can have multifocal disease. But let's say in this case the emergency physicians have already gotten a CAT scan that shows pretty dense subcutaneous stranding corresponding to the area of cellulitis in the groin and lower abdominal wall on exam, and subcutaneous gas down to the level of the fascia extending along the perineum and the proximal thigh. So you feel ready to make the diagnosis of a necrotizing soft tissue infection. Tiffany, how would you talk to the patient about this diagnosis?
I think this is a really hard conversation to have, because I think often these patients come to the ED knowing that they're sick, but they don't really know quite how sick they are. I will often tell folks that they have a really bad problem, and I sometimes have used the phrase flesh-eating bacteria to try to communicate in sort of lay terms, like how bad this really is. I will tell them that however it looks on the skin, we think that it's even worse underneath, and that they need an emergency operation to cut away what's dead and try to save their life. It's really important to set expectations at this stage and tell them, they're going to be in the ICU for several days. They might need to stay asleep with a breathing tube for a few days. They're almost certain to need multiple operations to make sure all the bacteria get removed, and then to try to close the wound afterwards. I think this, again, you want to know who they want to make decisions for them, or if they have any advanced directives or anything before they go to the OR, because chances are they're not going to be able to make decisions for themselves for a few days or even longer. It's hard because, of course, you never want to scare people, but they have to understand the gravity of the situation. If we think it's going to be a really extensive debridement, I will sometimes say right out that it's going to be a long recovery, and I expect this to be a life-changing operation, and making space for the emotions that come with that. And then, of course, ending with allying to say that we're going to be there to help them through this experience to recovery. But it's a hard thing to talk about with people.
Yeah, I agree 100%, specifically in these cases where what they see on the surface is often just the tip of the iceberg, and anticipating what surgeries they could need, whether it's perianal, perineal, and possibly a diverting ostomy, or for extremity, even up to and including limb amputation. To treat this problem, of course, any infection, we want to use source control and antibiotics. We'll get to the source control, but first, how would you think about antibiotic coverage in this patient?
I would definitely want the ED to start your antibiotics as soon as I make the diagnosis of an NSTI. I would want them to sort of get things rolling in. So you want to cover your target organisms pretty broadly. For group A strep is the sort of most common organism. MRSA is sort of slightly less common for single organisms. Clostridioides is kind of the classic bacteria for a gas-forming infection. But these infections are most commonly polymicrobial, and these patients are usually really sick, so you want to cover them extremely broadly. In our institution, we often use like a vancomycin, cefepime flagyl kind of regimen, plus an antitoxin. You could do something like vancomycin and zosyn, linezolid and zosyn, or piperacillin and tazobactam as the sort of non-trade name for zosyn. Would be a couple really broad options.
Yeah, I want to highlight what you mentioned there about antibiotics with antitoxin properties, because I think most of us heard that in relation to clindamycin, but there's been some argument more recently that linezolid may even be better than clindamycin in terms of antitoxin, especially given clindamycin resistance increasing since sort of the mid-2010s, although there haven't been large clinical trials to support that transition. Based on a recent case from Climate Resources for Health Education, the geographic footprint of Vibrio cases has been extending northward up the Atlantic coast as the climate changes. And this is sort of a specific bacteria that can cause horrible soft tissue infections. And in the 1990s was an infectious etiology that was limited to the Gulf of Mexico and now affects a larger area with cases reported as far north as Maine. Do you have any antibiotic recommendations for something like Vibrio?
If you, like us, are living in a landlocked state, you might not see Vibrio very often. So Vibrio is covered by cefepime, would be kind of some of the coverage that we had mentioned, but also other third and fourth generation cephalosporins. And then there's some evidence that if you're concerned about Vibrio, adding either ciprofloxacin or doxycycline can have a synergistic effect with the cephalosporin to address that as well.
Any additional antimicrobial coverage for immunosuppressed patients?
I would think about fungal coverage in someone who is known to be immunosuppressed. So we talked about our antibiotics, but of course the mainstay of treatment for NSTI is operative debridement. Early debridement is critical, and a delay in initial debridement past 12 hours has been associated with a dramatic increase in mortality. But of course, you want to try to get these patients to the operating room, within an hour of making your diagnosis. An initial aggressive debridement has also been shown to reduce the total volume of tissue removed. So there's no role for sort of trying to save tissue at your first operation. If I was going to describe this operation in an oral boards fashion, I would say that, after general anesthesia was induced, I would prep and drape the patient widely and begin over the area of greatest crepitus or skin necrosis. I would open the area widely and explore down to the level of the fascia. I would be sure to send multiple deep tissue cultures and aggressively debride any necrotic or compromised tissue. Sort of looking for, thin grayish dishwater fluid. Any planes or tissue that just sort of fall apart with finger dissection usually is not healthy. Muscle that's non-reactive to cautery and thrombosed capillaries and other microvasculature can be some signs for what to debride. If you're operating on an extremity, one of the things our faculty tell us is to debride the proximal margin first, because you don't want the infection to be spreading proximally while you debride something more distal that may end up being amputated anyways. And then my other tip for this is that you want to be sure to cross these patients for blood before surgery, because they're often already in shock, and then these cases can definitely get bloody with a really wide debridement.
Absolutely. A couple of points that you mentioned. You said the dishwater fluid. I think that's really pathognomonic for a really aggressive necrotizing soft tissue infection, because what that means to me is that your body is no longer adequately making pus, which would consist of these immune response cells, and so the infection is exceeding the body's immune system response. Another thing you mentioned is kind of the idea that infection does not keep pace for all layers equally. So, your preoperative exam, you mentioned you may have one area of bullae, but the patient has tenderness a foot away, and I think that tenderness can be more sensitive than the skin changes for understanding the course and extent of the infection you're going to have to debride. And then, as you mentioned, your debridement has to be absolutely uncompromising, especially in a life-saving situation. But sometimes you can preserve some overlying skin and soft tissue if, the deeper layers are dead, but the skin is well vascularized. And as you mentioned, looking for those thrombosed perforators and small vessels can sometimes be easier to visualize than, subtle differences in coloration of adipose tissue. Another thing we keep saying is necrotizing soft tissue infection, which is a move away from the old term nec fash. And I think the real difference is we are being more descriptive in defining what level the necrotizing infection is occurring at. So fascia would be fasciitis, but you can also have myonecrosis, you can have necrotizing cellulitis. So the necrotizing soft tissue infection is really the umbrella term that's going to incorporate all of that. So you've done your debridement. What is your dressing choice post-debridement and plan for dressing changes post-op?
Well, you want to be able to look at this wound at the bedside, especially in the first 24 hours. So, my first OR dressing, I would want to pack damp to dry with Dakin's damp gauze so that you can look at the wound again in about 12 hours or sooner if they're clinically worsening. Need to return to the OR for another look in about 12 to 24 hours. So, again, you're not looking for a very long-standing kind of dressing in place here.
Yeah, absolutely. I think there's a little bit of surgeon preference involved, but I like Dakin's, or sodium hypochlorite, also known as bleach. So for very contaminated wounds, the strength that people refer to is a little confusing in nomenclature because full strength is 0.5%, so half strength is 0.25%, and so on. But ultimately, Dakin's is pretty cytotoxic. So even though it kills bacteria, it's not great for healing. And so I typically will limit use of something that cytotoxic to just a couple days, especially if I'm getting a grasp on the infection.
So let's say at this point, this patient got an initial wide debridement of the mons, the perineum, the lower abdominal wall, didn't violate the peritoneum or the retroperitoneum, and then the proximal thigh. She's been getting her wound packed with Dakin's damp Curlex, changed twice a day. It's been maybe a few days and she's now off pressors. Her last dressing change in the OR yesterday really required pretty minimal debridement. You're confident that there's no evidence of advancing infection anywhere. How would you start to approach the care of a large wound like this?
First, if it is able to accommodate negative pressure wound therapy or wound vac, I think that has had an increasing role in management of these huge wounds, both in, mechanically decreasing the size of the wound, encouraging angiogenesis, and managing fluid in what are often moist areas. And I often will use an irrigating wound vac, particularly if it's a wound with some concern for fibrinous exudate or some level of biofilm still present.
How do you set up these irrigating vacs? I kind of find them a little confusing sometimes.
Yeah, I would say it's a lot of surgeon preference again. I typically am a more frequent installation, so often every 1 or 2 hours, but with lower dwell times, because anecdotally I've found that I have less leak issues with the sponge spending less time saturated. But for that frequency of installations, you don't want to be using something harsh like Dakin's or even a solution like Bosch. So I often will do even something like saline as my installation fluid.
When and how would you close a patient like this?
Yeah, these wounds can be extremely large and disfiguring, so my partners and I are aggressive about trying to close primarily what we can after the infection's cleared. Obviously, discuss with the patient preoperatively that at that point the surgery is sort of elective and they do have still continued risk of wound breakdown, but a loose primary closure where possible. I prefer a non-absorbable monofilament like nylon, and the size really depending on the tension in the wound and what you're trying to bring together.
What if you can't get part of it closed?
Understandably, sometimes the VAC is, again, the temporizing choice, but I think eventually consideration for split-thickness skin graft, often several weeks down the line to cover large defects more quickly. So you want to wait till they're starting to get some granulation tissue. But in cases where the patient's been debilitated by critical illness, I will sometimes use a skin substitute as a bridge to deferring their skin graft down the road when their nutrition and clinical status has recovered. The last thing I want to do is create another wound in a patient with impaired healing abilities.
That makes sense. Any particular products that you find helpful in kind of managing these complex wounds?
I personally have had success with Novasorb's biodegradable temporizing matrix, or BTM, but there are many other equivalent products on the market that serve this purpose. I think having a contact layer on the surface of the wound can improve dressing change associated pain and provide a layer for regulation of fluid loss and promote granulation tissue. And again, sometimes temporizing and trying to get the patient on the road to recovery is key. Understanding that this is a very multidisciplinary long recovery and you're trying to get their rehab with physical therapy, occupational therapy, and working together with your wound ostomy nurses, etc., to get them on that path. So Tiffany, this case was sort of a clear-cut necrotizing soft tissue infection. We had imaging. I didn't give you labs, but assuming the labs and clinical presentation in this case made the diagnosis clear. Let's say instead it was less clear. Maybe there's no gas on imaging. The patient maybe is immunocompromised with a bulle on their leg. What would be your next step to monitor a patient?
If it's someone that you feel is otherwise doing okay and maybe has just a wound with maybe some questionable features, you could consider watching and waiting over the next couple of hours to see if the wound changes. But if you're concerned at all, if the patient has any sort of hemodynamic compromise or is particularly vulnerable, you need to explore operatively to look at the tissue directly.
So what does that look like logistically compared to the aggressive debridement you'd previously described?
Theoretically, this is something that you could even do at the bedside, although I would say we would, probably do this in the operating room in our institution most of the time. You'd start with a relatively small incision, 3 centimeters or so, kind of like a muscle biopsy incision, looking longitudinally along the extremity. You'd want to dissect down through the fat and all the way down to the layer fascia, go through the fascia and sort of look at the muscle directly as well. So you're looking kind of full thickness, skin, fat, fascia, muscle. And then that way, if you see any evidence of infection, you move forward with a wide debridement. And if no evidence of infection or necrosis, then you can feel confident that you've excluded this sort of source of infection as kind of the cause of their clinical compromise.
Yeah, definitely. If the clinical concern exists, this is definitely a must. And I recently had a patient that had CT imaging with pretty low concern for NSTI, pretty average Larynx score, but she was clinically septic and neutropenic. And so we did this fascial exploration and sure enough uncovered a very rampant and progressive infection. And I would always rather go to the OR and be reassured than wait 4 or 6 hours for that repeat clinical exam and find the patient to be much sicker and now has an expanded area of infection requiring even further debridement or amputation.
Totally. Well, thank you so much, Dr. Kranker, for being with us today. We got through a ton of great information about necrotizing soft tissue infections. As always, if you're looking to learn more, you can check out a full review of wounds and wound healing in the Washington Manual of Surgery.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.